to finish off, we have a really pull it all together case presentation from Rebecca Ward, who is our current Paediatric Infectious Disease Fellow at Queensland Children's Hospital. Rebecca is going to, I'm not going to take your thunder away, so I'm not even going to tell everybody what it is, but I think this case does quite nicely bring together many of the different themes that we've been talking today about treatment of difficult to treat infections within the immunocompromised host. Thanks, Rebecca.
So this is an incredible case and that I've been given the privilege of talking about today. I joined the team about halfway through this patient's journey, so I actually want to start off by thanking both the patient and his family, but also the team at QCH, particularly Dr. Peter McNaughton, who's in the audience, and the rest of the oncology team, as well as Dr. Julia Clark and the rest of the ID team who managed this patient. So my title gives this away a little bit, unfortunately. So I'll start off. So this is a 2-year-old boy who was diagnosed in March 2023 with CD40 ligand deficiency and was treated with IVIG and prophylaxis and surveillance before going ahead with a bone marrow transplant from a matched unrelated donor on the 19th of October last year, with conditioning, as you can see there, with Campath. Sorry, I can't see the bottom of my slide there. So he was on infectious prophylaxis, and for his GVHD prophylaxis, he was on cyclosporine. So unfortunately, on his day 4 screening bloods, adenovirus was detected in blood with a CT value of 40. It wasn't detected on urine, and by day 6, it was detected in stool with a CT value of 13, and it was actually symptomatic with diarrhea at this point as well. And by day 7, the adenoviremia had reached 10 to the power of 3. So day 8, the decision was made to start first-line therapy with cidofovir at 5 milligrams per kilogram weekly. And a few days later, the adenoviral load was now up to 10 to the power of 5, and it was also detected on respiratory viral PCR with a CT value of 26, although he was asymptomatic. This was genotyped and was C2, which we know is one of the more common causes of adenovirus in the immunocompromised host. So quick refresher, adenovirus is a non-enveloped double-stranded DNA virus, with which there's 7 species. And as of March this year, there's now 116 human adenovirus genotypes identified. It's got an icosahedron capsid comprised of hexon proteins and fiber-like projections which bind to the host cell via the Coxsackie adenovirus receptor. It's globally distributed without seasonality, and it's usually causing infections in children, and it's usually self-limiting. And each of the serotypes are associated with different clinical manifestations depending on their cell tropism, and we know that it can establish latency. And very importantly, we need a good cell-mediated immunity to clear it, and we find memory CD4 T cells can be detected in most healthy adults. So in the stem cell transplant population, it can affect up to 15 to 30% of the pediatric population, whereas in adults it's less than 10%. And it has a really high mortality, up to 26% in symptomatic patients, and even reported as high as 80% in pneumonia and disseminated disease. And there's evidence that it can proliferate in the GI tract before viremia is established, and the levels in the gut can predict viremia going forward. Looking at mortality, the major determinants are essentially longer periods of adenoviremia, the peak of the viral load, and also the high 16-week AUC. And you can see in this graph here that that really affects survival. So our first-line therapy was cidofovir. So this is an intravenous drug, which is a nucleoside analog of cytosine that binds viral DNA polymerase, and it's got broad activity against double-stranded DNA viruses. And we're currently using it first line. The optimal dosing isn't quite clear, but usually people use the similar dose that we did. The efficacy is limited, and it's been reported between 60 and 100%, and Graza et al. Reported that viremia was controlled in only 54%. The main drawback of cidofovir is its major toxicity and nephrotoxicity, which is because it acts as a substrate for OAT1 in the renal tubules, also causes myelosuppression and uveitis. And the rates of nephrotoxicity have been reported by Vora et al. As being as high as 31%, and it has an associated increase in mortality because of that. This is our patient from the day he started his cidofovir. The blue line is his adenovirus load, and the yellow line is his fever. And as you can see, he wasn't really particularly febrile. I think he had a few spikes here and there. He also had this ongoing diarrhea, as I talked about before, and ended up having a scope and a biopsy, which showed that he had grade 1 GVHD, but also had an adenovirus PCR positive on that biopsy. So that, again, where's the diarrhea coming from? Is it graft versus host? Is it virus? Is it a mixture of both? But as you can see, the cidofovir didn't really make a dent in his adenoviral load. So we went on to another therapy with third-party virus-specific cytotoxic T cells that we had a great talk about earlier today. But unfortunately, those combination therapies didn't lead to an improvement in his viral load. And you can see that as his viral load increased up into the 10 to the power of 8, he also became quite persistently febrile. And this was his fever chart. So when I joined the team, he'd been like this for nearly a month already. And this unrelenting fever with tachycardia drove the family and the team to advocate strongly for another therapy for this patient, brincidofovir. So brincidofovir is a prodrug lipid conjugate for cidofovir. It comes in IV and oral formulation and has previously been accessed via compassionate access pathways. The oral form has been somewhat sequestered for smallpox, for which it's FDA approved, and also as an emergency access for monkeypox. It's got excellent oral bioavailability and achieves really high intracellular levels because of the lipid side chain, which allows it to be rapidly uptaken into cells before being cleaved into its active form. And importantly, there is no significant nephrotoxicity because it doesn't act in the same way on the OAT1 substrate or myelotoxicity. The main side effects reported have been GI toxicity from the oral formulation, as well as some hepatotoxicity. The major drug interaction to be aware of that was important for our patient as well is that cyclosporin can increase the plasma exposure of brincidofovir, so it requires dose adjustment. So oral brincidofovir has been around for quite a while. I found 9 papers that looked at it in our patient population, so the adenovirus in stem cell transplants. First one being back in 2010, a single case report. Essentially, what we see in these is that oral brincidofovir results in rapid, so within 1 week, drop in the viral load. Florescu et al. In 2012 showed a 10-fold drop in 60% of patients, and similarly, Grimley et al. In 2014, over 60% got the level below detectable limits by 1 week. And then by the end of treatment, it's up to 86%. The Prasad et al. Looked at oral brincidofovir from a safety perspective, and the main thing found was that there was GI disturbance in 45% of patients, but it was only severe in a small cohort of patients, and less than 10% had to stop the drug. They also identified a small transient rise in ALT, but importantly, again, no renal toxicity and no myelosuppression. And this is just another publication by Grimley et al., which showed, again, rapid drop in the viral load by 1 week, and only a 21% treatment failure. I think the important thing about this paper as well is it identified that 2 milligrams per kilogram twice weekly was the optimal dosing for oral brincidofovir and had the best outcomes. And the other thing that was interesting about this paper was that there was a large amount of people that had diarrhea, so 57%, but also 50% had graft versus host disease, which was usually gut, which again brings up that issue. Is it a drug effect? Is it graft versus host disease? Is it the virus? Another set of papers, so Hirokar and Paruccio both looked at comparing brincidofovir and cidofovir, and overwhelmingly found that brincidofovir was much better. So virologic response 83% versus 9%, or 67% versus 47%, with much less treatment failures. And the other thing to note as well is that in a group of patients who had failed cidofovir therapy, 9 out of 11 of them responded to brincidofovir despite significant lymphopenia. So my summary of all these 9 papers is that oral brincidofovir at 2 milligrams per kilogram twice weekly results in rapid and effective virological response, and is even effective in the absence of immune reconstitution. It doesn't cause nephrotoxicity or myelosuppression, does potentially cause some GI toxicity, but there were few treatment discontinuations, and this is confounded by the gut graft versus host disease. So our patient ended up getting intravenous brincidofovir, and this is the only publication that I could find for this patient group, and it's an oral abstract from last year giving preliminary results of the Athena study. So this looked at 27 patients less than 12 years of age and looked at 3 different dosing regimens for IV brincidofovir, 0.2 milligrams per kilogram twice weekly, 0.3 milligrams per kilogram twice weekly, or 0.4. And it found that clearance was very dose dependent. So they had excellent results with 4.4 milligrams per kilogram twice weekly, with 100% of patients achieving clearance, but that was much lower in the other treatment groups. Treatment-related side effects were observed in 7 patients and 6 discontinued treatment, but all of these were reversible and no serious adverse events were identified. So our patient commenced on IV brincidofovir. So started off initially on 0.2 milligrams per kilogram twice weekly because he was on cyclosporin and needs a 60% reduction in the dose because of that. But within a week, the decision was made to change him over to tacrolimus to achieve optimal dosing with the brincidofovir at 0.4 milligrams twice weekly. And he continued on his CTLs. And as you can see, the viral load steadily dropped after starting brincidofovir, and the fever chart matches beautifully. And so as his viral load came down, his fevers settled. He then also went on to get another therapy with, he got a CD34 boost, and he also got CD45 RA depleted T cells, which I'll briefly touch on. So these are third-party donor lymphocyte infusions, which have been shown to lead to rapid recovery of T-cell immunity post-stem cell transplant. It's apparently easier and cheaper to produce than CTLs. It's depleted of the CD45 RA to avoid graft-versus hosts, and we know that memory T-cells are less alloreactive than the naive T-cells. And a study I looked at showed no significant difference in graft-versus hosts and improvement in the recovery of virus-specific immune response. And Lee et al. Showed that in 50% of patients, they had viral clearance after just 1 infusion, which I thought was pretty amazing. So one of the things I wanted to spotlight for this patient was one of his main challenges was his liver function tests. So as he started on his brincidofovir, his liver function, which had been a little bit abnormal to start off with, deteriorated. So he had quite a significant rise in his gamma GT, but also in his bilirubin and his ALT, and became very visibly jaundiced. And the problem was, again, that question of, is this graft versus host? Is this virus? Is this drug? We held strong and kept going with the drug, even though there was some concerns that it could be contributing. But because we had seen such a significant improvement in his viral load and his fever chart, we were really happy with the response and wanted to keep going. So as we got this excellent response, we were able to stop his brincidofovir and his other treatments. And you'll notice here that his gamma GT, while his ALT and bilirubin steadily improved, his gamma GT went off quite significantly. And we don't really have a clear answer to why that happened, but thankfully it is on its way back down. So this is a summary of our patient's time. We've already gone over that a little bit, but you can see he's had his adenovirus has been undetectable over the last month or so. And he was able to be discharged after 188 days in hospital and is doing well at home at the moment. So thank you for listening, and thank you again to the team.
Thanks, Rebecca. I think that concludes the session 4 marathon, and I suspect Adam's got a few things to mention. Just want to add to that very, very nice series of presentations and a lovely presentation. Thank you, Rebecca. What she didn't say, and what I suspect many of you will be asking, is how did we get IV brincidofovir? Ask Pete there, who's so that is a very good question, and that's part of a whole other talk, which I think would be a really interesting one about the ethics of patient advocacy, the ethics of patient advocacy, both to their clinicians, to the media, and to the drug company. And that's basically what the conversation was, with a lot of discussions directly with the drug company across the consulting physician. The company were just at that point in time before they'd opened any compassionate use access, because it was the end of the IV brincidofovir trial. And they are starting to look at compassionate access now. But that was the window before we could get it. And if you want a good story, Pete will tell you about it. Thanks, everybody. I'll hand over to Adam.
Thank you, Julia. So that wraps up the meeting for today. I want to give a big thank you to those who attended both in person and online, and thank you so much for supporting events like this. We're all very energetic and have similar sort of passions and interests. I think you'll all agree that the topics covered today were incredibly insightful. We got to hear both from the translational aspect of bench to bedside medicine all the way to implementation of guidelines across healthcare services. So it was really, really phenomenal. And on that point, I'd like to thank the speakers. I thought they did an excellent job, as well as the chairs as well. I'd like to thank the co-chair or the co-convener of the meeting, Dr. Lada Sundak, as well as the organising committee in general. You know, it takes a village, as someone said earlier today, and I think that was amazing support, you know, organising such an event. A special thank you to Louise Godfrey and Luminita Vlad as a part of the CRE team. I mean, you know, tireless and just amazing in organising everything, and we certainly wouldn't have done this without you. Another thank you to our partners and industry sponsors for your financial support. That's incredibly important as well. Finally, I'd like to say we're going to send out a survey just to get a bit of feedback to improve, as well as all of the presentations today will be put up on the website. We want to keep the momentum going. I saw a lot of great conversations happening interdisciplinary, interstate. I'd love to see a lot of sort of research and clinical collaboration come out of this, as did from last year. And I look forward to seeing all of you and hopefully listening to you speak next year at the Brisbane Transplant ID meeting for 2025. Thank you very much.